Next, I want to introduce our keynote speaker, Dr. Bonni Goldstein. She specializes in cannabis medicine in Los Angeles. She specialized in pediatric emergency medicine for years before witnessing the amazing benefits of this treatment in an ill loved one. Since then, she has successfully treated thousands of adult and pediatric patients with cannabis. She regularly speaks about cannabis medicine at conferences and patient groups around the world. She clearly explains for us lay people like me the main aspects of cannabis and its medical applications. She's the owner and medical director of Canna Centers and medical advisor to weedmaps.com. Dr. Goldstein was awarded 2017 Medical Professional of the Year by Americas for Safe Access, and she was recently in the documentary Weed the People that was just come out. You can watch it on Netflix as well. I'd like to introduce her now and take the time.
Good morning, everybody. Thank you to Jana, to Whole Plant Access, to the other sponsors for putting this on. I think it's so important for people to get information, credible information. The internet's great, but sometimes there's stuff on there that's just shocking. And if you're making a decision for your health, for your child's health, for your family member's health, it's important to have good information. This is one of the things I love about what I do, is that I do get to just take the info. I'm a total science geek, so I totally geek out on this stuff, and then I like to break it down and then share it with everybody else. Because if we have knowledge, you have power. If you have power over your own health, you're going to make good decisions, and you're going to be able to reap the benefits of this wonderful plant. So I don't have a lot of time. I have a time person who's going to wave at me and let me know. So if I'm running late, let me know, okay? So anyway, I've been a doctor for longer than I want to admit. I did my training at Children's LA, and then I stayed on there to do critical care transport, and then I went into pediatric emergency medicine for a very long time. I loved it, and then I had a child, and then I was burning the candle at both ends. And after a number of years, I took a break. During the time that I took a break, I really believe things happen for a reason. A friend of mine got sick, but she asked me about medical cannabis, and I didn't know anything other than, oh yeah, there's this law, and oh yeah, we used it back in college. So I decided to delve into the science to see if there really was something there. I hadn't dismissed it, and I do find a lot of my doctor colleagues dismiss it immediately. They refuse to say, is there something here? But hopefully, things are changing for the better in terms of my colleagues. But I looked into it because my friend was really sick, and I couldn't believe what I was reading in the scientific literature. Everybody says there's not enough research, and that's true, but there is plenty of research to know that it is safe. They have been trying to find all the negative things for years. Remember, we live in a country where you're allowed to research cannabis for its detrimental effects, but you are not allowed to look for benefits. That's where we are now in 2019 as a Schedule I drug. You have to jump through 1,000 hoops to look for benefits. But if you want to do a study on how bad it is for you, you can find that out. In fact, Rhonda sent me a science article the other day, and she said, are they really saying that cannabis causes autism? Somebody decided to come out with that recently. Of course, without looking at the junk in our food, right? All the pharmaceuticals people are taking, and so on. Anyway, so after I helped my friend and really delved in, I decided to go back to medicine. I had taken a leave of absence from the ER. I went back started working in a cannabis practice, and I fell in love with it. The patients were all saying the same thing, and I know they weren't meeting in the parking lot saying, let's just tell her this so we can get our pot. They all said the same thing. I'm getting off pharmaceuticals. I'm a better wife. I'm a better husband. I'm a better worker. I'm a better parent. I'm sleeping at night. I just have a sense of well-being. How is it possible that all of these people with different conditions in different stages of life are saying the same thing about this medicine? So that's really when I fell in love with it, and this is what I've been doing since. I wrote a book called Cannabis Revealed, and then I also was delighted that I was asked to participate in sharing my findings with my patients with epilepsy with Dr. Dustin Sulak and Dr. Russell Sinedo. I don't know if you know Dr. Sulak. He's a cannabis doctor in Maine who's excellent, and then Dr. Sinedo is a pediatric neurologist at Seattle Children's Hospital. We shared our data and published in an article in Epilepsy and Behavior, which is a well-respected journal that is now acknowledging that CBD has some medicinal value. All right, this is what my office looks like. I don't know why everything's in black and white, but anyway, we have an office in Los Angeles. We see lots and lots of patients. It's a big catchment area. Our youngest patient's 6 weeks old, and I would have started him on cannabis at 3 days, but we didn't have the proper diagnosis, so we needed to wait. And my oldest patient was 100. I did a house call for her. If you had seen the box of medicines, it was unbelievable. 27 different medications at the end of life. Makes no sense. We have a changing demographic. Back when I started doing this in 2008, it was mostly people already using cannabis, had found good relief, and then just wanted to be part of a legal system. Now what it appears is that it's mostly people who are cannabis naive, who have already tried pharmaceuticals, I've researched online, and now are trying to find something more natural or something that works a little bit better for them. 85% of our patients that come in have already tried conventional medication. It's still, in this day, not considered first line for many conditions, and people do follow the advice of their doctors and then find out that they're really unhappy with their medication. Now I want to talk about the science, so let's get into that. So this is Dr. Meshulam. He's 89. He's from Israel. Back in early 1960s, he was a PhD, recently graduated, and he was looking he was curious about plants as medicine, and he was able to get a hold of some cannabis, and he was trying, remember it was the 60s, he's trying to figure out what in cannabis made you high, okay? So he was able to isolate different compounds from the plant, and he gave the isolate, almost kind of what Rhonda was talking about, isolated compounds to young healthy volunteers. They gave THC to young healthy volunteers, and they felt the intoxicating effects. They gave CBD to young healthy volunteers who said, nope, we don't feel high. And they gave, I think it was about 10 other cannabinoids, and they were able to narrow down that THC was the intoxicating compound. But you have to remember that shortly after 1964, we have the Controlled Substance Act that goes into effect here in the United States and effectively shuts down a lot of research. In 1970, it was put on the Schedule 1, which it still is. I'm not allowed to write a prescription for cannabis. I'm allowed to write a recommendation. Schedule 1 means no medicinal value. That's not true. High abuse potential, that's not true. And lack of safety, and we know that's not true. So cannabis does not fit any of those criteria where it still lives. Anyway, it took a long time to figure out, yes, we know THC causes the high, but how does it cause the high? And in 1988, there was a major scientific breakthrough led by a female scientist at St. Louis University. I'll go into that. And then shortly after that, another breakthrough, which was the discovery of the endocannabinoid system and endocannabinoids. So discovery of THC, I've already mentioned. They isolated THC as the intoxicating compound, but the mechanism of how THC worked, it was 24 years before they figured out exactly how THC works in your brain. So let me show you how this works. Sorry, I skipped a slide. In 1988, scientists were trying to figure out how THC made people high. And remember, in 1988, we have the Schedule 1 in place. You cannot research natural cannabis. So they took synthetic THC and they put radioactive dye attached to it, and they followed it in a rat's brain. And every single time, there we go. Can you guys see that? Every single time, pretend this is the THC with radioactive dye. It went, in through the bloodstream, and then it would attach to this, what we call the receptor. At the time, it wasn't called the cannabinoid receptor. Scientists knew about that receptor, and it was called an orphan receptor. Think of a receptor as a lock, and the chemical compound that binds to it is the key, okay? So this receptor was called an orphan receptor because they did not know what compounds were binding to it. It had been seen in the scientific literature. It had been seen on electron microscope. Scientists knew it was there, but they didn't know its function. Lo and behold, we give THC to rats with radioactive dye, and THC sticks onto that receptor. Every receptor you have in your body, you make the key for. Dopamine receptor, you make dopamine. Serotonin receptor, you make serotonin. Opioid receptor, Okay, you don't make Vicodin, you make endorphins, right? So every receptor system is set up that there is a chemical, which is the key, and the receptor, which is the lock. So the scientists knew, here we have this receptor, we're calling it an orphan receptor, but THC binds to it. THC is a cannabinoid, we're going to call it a cannabinoid receptor. But guess what? We must make something within our brains or bodies that binds to that receptor, and they went in search of. And it took them 4 years, and they discovered that the cell kind of connected or on the receiving end of a message, and I'll go over that in a second, makes a cannabinoid-like compound to go back up and stick to that receptor. We do not have these receptors for THC in the plant. We have them because we make our own inner cannabis. We make our own inner THC. Everybody in here makes it, okay? Now here's the science. I'm sorry to give you flashbacks to high school biology. So this, sorry it's not coming out so great. I don't know if we can lower the lights a little bit, maybe? Anybody? I don't know. Anyway, this is supposed to be kind of like a globby looking, this is the end of a cell, thank you, and this is an end of a cell where they meet. When I was in medical school, I learned that this cell talks to this cell in a one-way fashion, and it turns out that that is not true. There is a feedback loop, and the feedback loop is the endocannabinoid system. Boy, I'm terrible with this thing. All right, so what happens here is there's neurotransmitters like serotonin, dopamine, GABA, there's all different kinds. They get released out, sending a message from this neuron to this neuron. They attach to their receptor, and this cell then sends it to the next cell and so on. Let's say an area of your brain, you're getting chemotherapy, area of your brain that controls nausea and vomiting picks up this poison in your body, so to speak. And what happens is that, let's say these cells are located in the area of your brain that control nausea and vomiting, you get an overwhelming sense of nausea because that part of your brain is firing. It is telling you to feel nauseous, which is a good adaptive behavior. However, what's happening is when there's too much message being sent on the most part, sometimes it's not enough, for the most part it's what we call an excitatory message. Lots of message. Think about pain, anxiety, seizures. Think about a child with autism who's kind of bouncing around and flapping and can't control, right? That's a lot of what we call neuroexcitation. Lots of neurotransmitter being sent. In a healthy brain, what is supposed to happen is when there's too much, the cell receiving the message gets annoyed, it gets perturbed. And what happens is that calcium channels open, calcium goes up in the cell, turning on a factory that makes your inner cannabis, which goes backwards back to the cell. It sticks on to the cannabinoid receptor right here, this loopy looking thing. And you see the key in the lock. And that tells this cell, lower your calcium, which then sends a message, turn down the neurotransmitters. If you've ever seen anybody who's violently ill from cannabis, from chemo or a migraine headache where they're throwing up, they literally take a puff and they're better, right? It's not magic. What's happening? And what's happening is that THC, as you can see here, is binding to the receptor. This receptor is meant for our own inner cannabinoid-like compounds, but sometimes we don't make enough of those, or we've used them up, and you can override with cannabis. Does that make sense to everybody? Okay, it's just a feedback loop. I like to use the analogy. If you are a type 1 diabetic, your pancreas stops, the cells get damaged and your pancreas stops making insulin. Where do you have to take your insulin from? An external source. If your thyroid poops out on you and you have low thyroid, hypothyroidism, I bet you there's a lot of people in here who have to take thyroid medicine because it's fairly common. What do you take? Thyroid medicine to replace. So when you take cannabis, you're augmenting or replacing the cannabinoids that you already make. This is why there's so few side effects. We have a system that is set up to handle these compounds, okay? So what we like to say about cannabis is the endocannabinoid system is it's a signaling system that sends messages to promote balance. So the goal is this cell's sending too much, let me tell it to dial down, get back into balance, okay? Now, if we look at the map of the receptors, this has been very well mapped out, and what you can see here are all the areas of the brain where type 1 receptors, and you like to think about type 1 receptors from the neck up and type 2 from the neck down. It's not exactly anatomically correct, but close. And you can see lots of different conditions here, right? And pain, nausea, vomiting, emotion, mood, appetite, cognitive function, memory, fear, motor coordination, pleasure, and reward. And this is a lovely, if you ever get a chance, the Canadian Consortium on the Investigation of Cannabinoids, the CCIC, they have wonderful educational stuff online if you ever want to check them out. But they made a very nice map of this. And then throughout the body, what you can see is this is supposed to be red and yellow densities, and you can see red in the densest areas. So think about where this is in the body. Your immune system, homeostasis, staying in balance, right? Your immune system is basically your body's way to interact with the external world. We constantly have things coming at us in our immune system, which, by the way, is devastated by a lot of the food that people are eating and all the chemicals in the food. It's a huge area. If you look at children with autism, I even bring it up, they're much more likely to have immune dysfunction. It's connected to the brain as well. And then we look here as well as the gut, okay, reproductive organs and other sites, and you can see where it lights up. They've even found connective tissue in your skin, in your pancreas, in your liver, in your heart, in your lungs, everywhere. Basically involved in every physiologic function that we have as humans. Again, the role of the endocannabinoid system is to maintain homeostasis. Dr. Vincenzo Di Marzo is a PhD out of Italy. I think he's now working in Canada, but he came up with this quote, and I say it in every lecture. The endocannabinoid system is essential to life, and it relates messages that affect how we relax, eat, sleep, forget, and protect. That's our essence as human beings, right? I have people that go, oh yeah, no, that's not working, that's not working. They go right through that checklist and say, can you fix all that? It is still astounding to me as a physician that 99% of my colleagues are ignoring the endocannabinoid system when they are taking care of patients. In general, people with endocannabinoid issues, they often look well, but they don't feel well. This is on a cellular level, right? So we have to remember that. And the classic is somebody who's been doctor shopping, they've been seeking out care, they've tried multiple different pharmaceuticals, and they're just not getting well. And wait till you see the list of conditions. So here we go, endocannabinoid deficiency. Dr. Ethan Russo has looked at or had proposed this idea back in 2003 that maybe for some people they don't make enough of their own endocannabinoids for whatever reason. Just like a person who has Parkinson's doesn't make enough dopamine and we give them dopamine replacement, maybe people who are finding real benefits with cannabis are finding that because maybe they're not making enough of their own endo within cannabinoids and they need replacement. And sure enough, since he posited this theory in 2003, all of these conditions have been found to have some evidence of endocannabinoid deficiency or dysfunction. Okay, I have a family member who has migraines, fibromyalgia, and irritable bowel syndrome, which is exactly what Dr. Russo put on there, who has completely turned her life around from being a sick person who could not get out of bed and go to work to now fully functional, simply using a handful of tinctures. Everything she tried before, I always call it, it's like putting a Band-Aid on your toe when you have a cut on your arm. It makes no sense to take, if you have an underlying endocannabinoid issue, it makes no sense to take medicine that does not target that. All right, and here's some articles that I pulled from the journals that just show that in the research world, there's a ton of research going on in this field, a ton of it. It's just hard for it to kind of move into the clinical, again, because of that Schedule I status and that illegality. And doctors as a group are a pretty fearful group, and we're afraid someone's going to come along and take our license away. But the reality is there's research ongoing, and we definitely need more, but there's enough for me to know that there's benefits here. So if you look at this first one, plasma anandamide concentrations are lower in children with autism spectrum disorder. This came out of Stanford last year. Well, if your child is low on anandamide, are you going to leave them that way? Should they stay low on anandamide, or should we try to replace what their deficiency is, rather than giving an antipsychotic when your child's not psychotic, your child has low anandamide? So part of doing this is understanding that we may not be able to measure this just yet, but it does exist. Here's one, this is about epilepsy. This one is about stress and anxiety. Boy, isn't everybody stressed out these days. Endocannabinoid system is a target for the treatment of motor dysfunction. The emerging role of endocannabinoids in migraine. Here's one talking about PTSD. This is only a handful. There are thousands and thousands and thousands of articles coming out, and if you're interested, the easiest way to look it up is to go online for free. Google Scholar has every article. Okay, and you may have to pay for an article, but sometimes you can get the article for free, and there's also PubMed online that you can look at if you're interested in a certain condition. And the words you would put in are endocannabinoid, anandamide, and then put the condition and start searching that way. Now let's transition from the science over to the plant. What was your question? Well, so it can happen that way. If you were to take a puff of some THC and low anandamide was your issue, it might actually make you feel happy, and it might make you feel not depressed for the moment. For some people, I mean, we all know that there's people use cannabis in different ways. There's people who use it multiple times throughout the day, and other people take one puff and say, oh, I feel better for 3 days. Depression is one of the conditions where they've looked at and they have found some evidence of a dysfunctional endocannabinoid system. So it's what I've explained to you is kind of a simplification of it. It's much more complex. We're talking about a complex plant and a complex brain and trying to find what works. But underlying that is the concept, is that you are replacing your endocannabinoids with the plant cannabinoids that we call phytocannabinoids. They're mimicking what your brain might be missing. Mm-hmm. No, that's a different mechanism. So you're asking me that's talking about tolerance, and I have a slide on tolerance, and I'll talk about that. Yep, it's a good question. So what's in the cannabis plant? There's over 500 natural compounds. What you see here is the flower. I mean, my generation called it the bud. When somebody told me it was a flower, I was like, what? So that is the flower. And if you look up close, you see these little antenna-like protrusions here. If you could grab one of these and squeeze it, which you wouldn't be able to do because they're very tiny, but these are called the trichomes, and that's where all the action is. That's where all the cannabinoids are being made. And remember that within that little trichome are all these different cannabinoids. The plant has over 100. I think the last count was about 110. There may be more. Many of them are not named yet. They just have numbers. But basically, Mother Nature packages this all together. And Rhonda mentioned isolates. Isolate is when you pull one out. So, for instance, there's a pharmaceutical grade CBD that's out. And what they've done is they've pulled out CBD away from all the other compounds. If that works, great, but I'm in favor of whole plant. I never handed somebody an apple and said, can you pull out one vitamin, right? Mother Nature kind of packaged it that way. I know I sound a little hippy-dippy saying that, but it's really, I really believe that the plant, and because we have so many different varieties of the plant, and so you can get high CBD, you can get high CBG, you can get high THC. There's so many different variations that you will likely find something that can work for you. But at the same time, our studies show that these compounds can enhance each other. So anytime you have much more CBD than THC, CBD blocks the intoxicating effects of THC. CBD blocks any type of paranoia or anxiety you might get from THC. You have a lot of people that come in and say, oh, I just want CBD only, I don't want any THC in there. Small amount of THC in there is very important to continue to get what we call the entourage effect. And exactly what Rhonda said, they work in concert with each other. They assist each other to give the benefits. All right, so here's a great slide that shows raw versus heated versus aged, the handful of the different cannabinoids. So I don't know if you can see this. It's supposed to say CBGA. I can't see that from where I am. CBGA is the parent compound, which then, depending on the genetics of the plant, can go into basically the lines THC genetic lines, CBD, CBC, and CBG. A on the end means it's raw. It means if you buy a little tincture or something like a tablet, it says A on the end, you know it was not heated in the process, it is the raw form. If you get something that's labeled THC, CBD, CBC, or CBG, or it doesn't have the A on the end, you know that in its course of becoming a product, it was heated in that process. Sometimes you can find products that have both A and what we call the heated compounds. So there is actually a product on the market right now that has THCA and THC. There's multiple. So you know that it probably wasn't heated all the way, or they mixed. They took a raw and they took a heated and mixed them together. So it's always good to know what you're getting. Once cannabinoids lay around for a while, they become aged. One of the most common ones being used is CBN, which is cannabinol. That's the only one I've really seen on the market. There is one company that has Delta 8 THC, which isn't really aged. It's a isomer of this, but CBN is on the market. All of these compounds have their own list of medicinal properties, and then when combined, tend to give an enhanced effect. Does that make sense to everybody? That's the idea behind the entourage, okay? Oh, is that not showing up? Oh, right. Well, that was supposed to be a slide showing, for some reason my picture's not showing. It was supposed to show a test result, but Rhonda already covered that. So remember, anything you get in California now, because we're regulated, has test results that go with it. And often they've been tested multiple times. So we can now be pretty accurate in California that if you buy a product, it is labeled properly for the most part. That was not the case just a few years ago. Terpenes are the essential oils, just a fancy word for essential oils. What gives cannabis its stinky smell is not THC or CBD, it is the terpenes. Dogs at the airport to smell out drugs or whatever are trained on the terpenes because you don't smell THC or CBD. And basically remember that all these different terpenes in their own right have their own medicinal effects, and often when combined with, so for instance, beta-caryophyllene combined with CBD gives an enhanced anti-inflammatory effect. There's one I didn't put up here called linalool. Linalool is what's in lavender. So if you hear of Granddaddy Purple, Grape Ape, Purple Haze, those are names of strains, that might give you a hint that those are high in linalool. The names often don't mean anything. I saw a strain the other day called Charlie Sheen. I'm not sure who wants that strain, but maybe it makes you act crazy. But I'm sure it had some other name beforehand, and sometimes the names do give you a clue, okay? But the whole point is that it is important to know terpenes. It's very disappointing to me that the state of California does not require terpene testing on every label. I would want to know that. When I go into the grocery store, my doctor said take more calcium. I look at the list. I can see calcium on there. It may not be the first thing you think of when you look at calories and fat content, but if you're looking for something in particular, it is very helpful to have the terpene profile. I know Rhonda has a lot of test results from various products, and we often test for, when I'm testing products, let's say a family comes to me and says, oh, we're using this particular product and it's coming from the underground market, I'll say, look, that's a deal breaker for me. We got to know what's in this product, and we get it tested, and we always get the terpenes tested so we know what's in there. But when you look at products, oftentimes, if you know the terpenes, you can figure out what might be helping you. By the way, how many people here have heard the words indica sativa? Raise your hands. All right. So a lot of people. So indica sativa, those terms are being used inappropriately by the cannabis industry. Okay, indica, people joke around, indica puts me into couch, and I know it makes me sleepy. Have you heard that before? Yeah. Sativa is supposed to be more stimulating. Really, the difference in those strains, okay, what they're trying to tell you is something with indica is usually what we call a high myrcene strain. Myrcene plus THC makes you sleepy. Think about it. If you take a strain that's high in THC, and another strain that's high in THC, but they make you feel different. Well, they both have the same amount of THC. It's not that. It's what it's combined with, okay? So myrcene is something that we know is very sedating. High myrcene strains tend to be lumped into the indicas. So really, again, it goes down to the terpenes that help give the effects and are synergistic not only with each other, but with the cannabinoids, giving some patients really what they're looking for. You know, I don't know if you guys know Kyle Turley. He's a big cannabis advocate. He's a ex-football player, NFL football player. He told me it took him 6 months to find the strain that saved his life. So he had to try different things to try to narrow in on what helped him, and it would have been so helpful for him to see, okay, this has this list of terpenes, and that didn't work for me, maybe now I can switch, rather than just experimenting. So I do find that the terpene profiles can be very helpful. And I do put up here, if you ever get a chance, this is free online, just if you Google Russo Taming THC, it's a wonderful article that lists all the effects scientifically shown for cannabinoids and terpenes. It's a little bit dated, but at the same time, it's really a terrific place to start, and a wonderful article if you can get that. All right, raw cannabinoids, I already mentioned, THCA, CBDA. I'll tell you a really quick funny story. Years and years ago in my practice, a big bodybuilder came in, and he had torn his bicep, and he was having a hard time getting back into, it had been fixed, but he was having a hard time with the opiates. And so he came in, brought me all his paperwork, and he was adorable. And I said to him, so how do you take your cannabis? He says, oh, I eat it. I said, oh, so you're using the edibles? He goes, no, I eat the raw cannabis. And I was like kind of looking at him like, okay, I've talked to thousands of people. Not one eats raw cannabis. I'm like, what are you talking about, right? He said, it works. It's anti-inflammatory and I'm not high. Well, you know, I approved him and let him go about his business. And I thought, gosh, that guy's kind of crazy. And lo and behold, he taught me something, because these are very potent anti-inflammatory compounds that don't have an intoxicating effect. You do not, we used to think that you had to heat the plant, i.e. smoke it, bake it in a brownie, to activate the medicinal properties. Well, yes, you have to heat it to get THC and CBD, but that's not the only medicinal compounds in the plant. We know now that THCA and CBDA are working beautifully. I'm seeing beautiful results with THCA in kids with autism. It's anticonvulsant for some kids with epilepsy. I have a little girl I take care of who takes a combination of THC and CBDA together. She has a syndrome that causes bone deformities, and she lives with pain every day. She's about 12 years old. She went from being bedridden to, she ran like this little school marathon on THCA comboed with CBDA. We cannot ignore any of these compounds, and I know research has been hindered, but just by not heating the compounds, you actually have a pretty potent medicine, okay? I have patients that take it in oil or juicing. There's lots of terpenes, remember, because when you're heating it up, you cook out some of the terpenes. Many of the companies that make these products try to retain the terpenes in the way that they're doing the extraction, and there are people here who know a lot more about extraction than I do, so they're on that plant side of it. And if you have questions about that, I'm sure they'd like to answer. Just THC as far as I know. All right, so let's move on to clinical. So most common pediatric conditions, you can see it's a huge long list, okay? The majority of the patients that come see are have epilepsy or autism, but also I see a lot of cancer patients, kids with ADHD. I see a lot of kids OCD. ODD is oppositional defiance disorder. These kids just really have no sense of safety and no sense of other people's safety. They are running off, leaving the school, eloping, and so on. Eating disorders, I've had some good success with. Tourette syndrome, chronic pain, and autoimmune, genetic conditions, and certainly end of life. I show Thomas up here. Thomas's mom has given me permission to speak about him. Thomas has an unknown genetic condition. He's self-injurious, lots of seizures, developmental delay, and constant vomiting. And he came in a wheelchair the first year, and they were told he wouldn't walk. And the second year he walked into my office. He's weaned off almost all of his drugs, and he stopped vomiting as kind of a perk. Mom didn't even expect that effect, but he stopped vomiting. He's growing. The self-injurious behavior is down, and he's just a sweet boy who now has had some incredible improvement in the quality of his life, doing really well. And he is on a combination of CBD, THCA, THC, and probably others. I just can't remember off the top of my head, but how did we get there? We started with one, rule it in, rule it out, move to the next one, rule it in, rule it out. If you're keeping it in, you layer the oils on top. If it's not something that helps, we jettison it. Okay, you have to have a method in order to figure out what works. One thing at a time. It takes a long time to figure it out sometimes. Some families get lucky and it's the first thing they try, as Rhonda mentioned. Common adult conditions. By the way, that's my 89-year-old dad. We went for a walk while I was back east. He is a cannabis patient. He's using cannabis. Still works 5 days a week in a quilt shop cutting fabric at the age of 89, and he thinks cannabis is the best thing ever. And I grew up with him telling me dope is dope, whether you shoot it up or smoke it. I don't ever want to hear you, because he is from Reefer Madness. He saw it when he was a kid. Okay. He also has a brother who had some real issues with drugs, crack and meth and whatever else. So he's really anti-cannabis. I got my mom started on cannabis for pain and sleep, and he's sitting there back watching. And then he comes around, I think I need some of that too. So anyway, he's doing great. He will sleep the entire night. We're used to wake up 5 or 6 times, and he just thinks it's the best thing ever. So I'm sure that has a lot to do with his energy. This was actually, we were out on a 2-mile walk at 89, so that's pretty good. Anyway, these are the conditions: chronic pain, cancer, anxiety, depression. You have to remember, a lot of conditions overlap. When you have cancer, you have pain, you have nausea, you have anxiety, you have depression, you're not sleeping. I sometimes will boil down to patients that all illnesses have their different things that come with them, but anxiety, pain, and lack of sleep are all something that are very common across illnesses, and cannabis treats those. And we may not cure you of your condition, but you can manage your life so much better when you feel that tonight I'm going to get some sleep. Tomorrow I'm going to be able to get up and get out of the house and run my errands or go to work or take care of my kids. That's something that cannabis does very well. All right, rationale for use. This is, we know about endocannabinoid dysfunction. So if there's some evidence in a patient that they have some endocannabinoid dysfunction, there's no reason not to try cannabis. And look, every article I read, I got very lucky back in 2011. I was hired by a company to develop a cannabis program for them for doctors, which never got off the ground, unfortunately. But they basically paid me to sit in a room and read and develop. And so I got to sit and read just about every article that came around for about 9 months. I got really lucky. And everything you read, if it's legit, right, it says well tolerated, mild side effects, well tolerated. I mean, see it and hear it over and over. But yet if you talk to people who are still under the reefer madness, it's the most dangerous thing. So the reality is that the scientific community has come around to it is well tolerated. Now let's try to figure it out. No organ damage. Now there is some recent literature saying that CBD can harm your liver. I do not see that in my patients taking mega high doses of CBD. It may be the preparation, it may be what they're testing. There is a new pharmaceutical out with CBD, which I'm not going to get into because it's like politically incorrect to talk about it, but it has a lot of ethanol in the product. What does ethanol affect? Your liver. So at really super high doses, you may be getting a cross effect, and it really saddens me because the CBD and in my population of patients, I have not seen CBD affect liver function tests, but we are seeing that with some of the new isolates out because of what else is in the bottle. You have to remember there may be something else in that bottle. Okay, quality of life we know is important, and then again, compassionate care and end of life goes without saying. And then of course now we have lots of tested products. If you get a product and it's not tested, move on. Make sure you get something that's tested. There's so many good products out there. And people always ask me, what's the best product? Well, it's the one that works, right? So, but make sure it's tested. Make sure it's something that is reproducible and that you can get it again. This is 2 siblings, both have, do you know them? Gav, yep. So this is Gavin and Casey. These both kids have epilepsy and autism. They presented a little bit differently, him mostly epilepsy and Casey mostly autism, but they're siblings who were really struggling, and now they're both in school. They're both doing incredibly well, both really bright, and their mom is kind of an advocate and out there sharing information. In fact, Gavin's I think the first patient in my book that I talk about. So, and mom likes to send me the first day of school pictures, which I love. All right, so epilepsy, we're going to talk about that. How many people here know somebody with epilepsy? Okay. My mom had epilepsy, and then my father had a head injury that gave him seizures. So both of my parents have been on epilepsy medications, and I wish I could go back in time and undo all that, because it was devastating for them. So it's a pretty common condition, affects 1% of the world population. The most important thing to remember is 30% of patients are not responding to the medication. That leaves a lot of people uncovered. The incidence of childhood epilepsy is much more common than adults. There's a definition called intractable epilepsy. Intractable means not responding to medicine, and that comes after 2 medications have been tried, either separately or together. The chances of responding after 2 drugs do not work is somewhere between 1% and 4%, depending on the study you look at. And of course, the burden in children includes that these are developing human beings that are having seizures, that are brain damaging, that are also causing issues with behavior and motor, and interfering with their ability to learn and move forward in their lives. Now, I just did a summary of the recent research. So if you look over time here, Dr. Hussein is a pediatric neurologist at UCLA, and they surveyed 117 families using cannabis, and they found 85% overall response rate. That's pretty good, huh? 14% of these kids, who are all considered intractable, meaning nothing works, found seizure freedom. That's a pretty good number. And as you can see here, this came from Israel in 2016. Their group wasn't as large. I think it was 74 patients. 89% overall response reported some reduction in seizures. 1 patient became seizure-free, and they felt that maybe their seizure freedom number was so low because they stayed under a certain amount in terms of dosing. They did not explore higher dosing in that group. This is Dr. Sulak, the paper that I participated in. 86% overall response rate, 10% of our patients became seizure-free. And then there was an article that came out after, 39% of patients, they kind of, how you assess your data can change how it kind of looks on paper, all right? So 39% had a greater than 50% reduction, and they also saw 10% of seizure freedom. So it's not like every child coming in, we're making seizure free. But many families come in 50 seizures a day, and they will end up with 1 seizure every 3 weeks. They will take that. That is a big improvement, especially since there's very little side effects once you can dial it in. The other thing is we can use CBD, and then sometimes we layer on THCA, and sometimes we layer on THC, and we get more of a cumulative response. Do you have a question? Okay, so for all of these are not studies where they gave the patients. These were surveys of patients using CBD. These are all whole plant. CBD-rich cannabis, these are all whole plant. Right? These are all whole plant. In Israel, they used a 20-to-1 ratio. In Dr. Hussein, remember, they're all using different because it was a survey of 117 patients. Many of them are my patients that he included in his survey because I'm right down the road from them. In our group, Dr. Sulak, we used ranging ratios 30-to-1 all the way down to 1-to-1 ratios. There's a big variance in terms of what the families were using, and also in terms of whether or not they had added in THCA or THC. Some of them had already done that. We included them because, we're trying to, and all patients in all of these had used cannabis for at least 3 months and were basically steady on their cannabis dosing at that point, okay? All right, this is the article that I participated in. Here you can see seizure freedom's 10%, 76 to 99% reduced about 28%, and then over 50 to 51 to 75%, sorry about that, a little bit over 15. If you add that up, that's quite a number of patients who came in saying, you know, we've been on 13 drugs and nothing has worked. So what this does is this gives families a chance to try something else rather than starting with a drug that is very low chance of working. And by the way, we saw side effects. Increased alertness, better sleep, improved mood, less rescue medication, less ER hospitalizations. So to me, those are all very acceptable side effects. I would say to you that, remember, this was not in a trial where I was directing, like, you have to take 20 to 1, this particular strain, and we're going to titrate up. Studies are different than what we're doing clinically and then looking back. If somebody in my practice had a problem, mom calls and says he's sedated, well, I kind of change things up, right, to get rid of that side effect. So you have to remember that when I'm reporting side effects of sedation, people may report it, and we counted that, but we can also change that. It's not something that they have to stick with, okay? In a trial, you're under trial guidelines, and you kind of have to stick within those trial guidelines. So for medical care, like a doctor like me, so we're cash pay, but we give you a bill and you can submit it to your insurance company. For the products, insurance is not paying yet. Yeah. And it's expensive. CBD can be expensive, and that's why it's important to know how many milligrams how many cents per milligram you're paying. I go over that all the time with patients. Whole Plan Access has that wonderful calculator online so you can access. People get caught up in, oh, I want the best, and then you might meet somebody and they say, oh, it's the best, and they may be doing everything right, but there's no sense to pay 20 cents a milligram where equal quality might be 5 cents a milligram, especially, again, long-term high doses. Lower doses, it's a little bit easier to have some leeway between products. Now, how does CBD stop seizures? So it's not magic, right? So the way it works is it helps to inhibit that neuroexcitation in the brain. And the way it does that is multiple ways. One thing that CBD does, which is fairly new to learn about, there's this receptor in your brain called the GPR55 receptor. It is a receptor that is outside what we would call the endocannabinoid system, but CBD interacts with it. When CBD blocks this receptor, it lowers an excitatory neurotransmitter called glutamate. Glutamate's another neurotransmitter in your brain, like serotonin or dopamine. But in seizures, it accumulates, and its accumulation can be toxic to the brain and cause more excitation and more overfiring. So to have CBD work indirectly to decrease glutamate by interacting at this receptor, you're getting decreased excitation. And it also, by blocking this receptor, increases GABA. GABA is a calming neurotransmitter. So you're getting more GABA, more inhibition, calming, and you're getting less excitation. So it's pushing the brain from that overexcited state back into a more balanced state. That's one of the mechanisms. One of the other things is that CBD is a very potent anti-inflammatory. If you think about, we know with autism, children have neuroinflammation. We know with epilepsy, pharmaceuticals don't address inflammation. It's one of the reasons that people will often use special diets for their children. We know that ketogenic diet, modified Atkins diet, avoiding sugar and sometimes dairy and so on will help. Part of that too is helping, there's its own mechanisms, but some of that too is helping to prevent some of the inflammation that's going on in the brain. We know that CBD does not bind to either of the cannabinoid receptors. It acts, I call it the traffic cop. It acts more like a modulator. It helps direct what's going on at that receptor. And what we also have found is that there are about 65 different sites in the brain where CBD works. So if you take one dose, you should not assess right then and there if CBD is for you, because it can take time. We're asking a plant to change our neurochemistry. That's a big ask. You have to give it time. I have some families it takes 6 months. I have some families it takes a year. I have some people that respond very early on and say, boy, this is my medicine, I know right away. I've had families, in fact, Thomas's mom, the little boy I showed you earlier, she said to me, it just keeps getting better and better. Well, what's happening there is he lived 10 years out of balance, let's say, and it's just taking time to get him back into balance. And again, this is a plant. This isn't some really heavy-duty pharmaceutical. You have to give it a chance to work. And I like to use the analogy, if I hit the gym, if I'm really out of shape and I hit the gym tomorrow, I'm not in shape tomorrow, okay? Cannabis, you have to give it time. Let it work. Don't decide right away. If you're not getting good results, you can tweak things, but don't give up on it, because it can take time for it to work for certain people. Now, other anticonvulsant cannabinoids, I'm not going to go in, but if you want to take pictures of the slides, go right ahead. CBDV, THCA, CBDA, these are all been shown to have some anticonvulsant effects. CBDA, I've only seen anticonvulsant clinically. I haven't seen any studies on that. CBN has had some conflicting results. Delta-8 THC, you develop early tolerance. Now, THC is interesting. There are people who say, oh, no, it causes seizures, or no, it doesn't cause seizures. It does both, okay? THC in low doses is anticonvulsant. I have some adult patients who manage their epilepsy just by taking a few hits off a vaporizer every day. Other patients need to take CBD along with it. Again, remember, every human being is different in the way they respond to cannabis, but it's very important to understand that the conflicting data in animals, when we talk about a proconvulsant, meaning it causes seizures, most of those studies were using very, very high doses that nobody would just take, right? Now, I will share with you that I did have 2 patients just take really high doses, and both of them who are non-epileptics, 180 milligram THC candy bar. By the way, if you're brand new to THC, you might start at like 2.5 to 5 milligrams. They each took 180 milligram candy bar. Prior to legalization, you could buy that. And they each it caused a seizure. So you have to be very careful. I understand the whole concept now behind the candy bars is, when you see a candy bar, you eat the whole thing, right? No, not when it's cannabis candy bar. So it's very important to understand that it's high doses. I give low doses to children with epilepsy, and we titrate up. And with children, it's a little bit different because their endocannabinoid system's immature. But some of them, the only way we can get full seizure control is to add in some THC. The problem with THC all by itself as a medicine is that if you start to escalate the dose, you'll develop tolerance. You do not want tolerance for a medical condition just called epilepsy. You just don't want it. Some of the families I take care of whose kids have autism, THC is what works. It's what works the best. They tend to escalate the dose, and at some point, we sometimes have to do a reset or a reboot, which I'm going to talk about. And it's not very pleasant because you have to take away some of the medicine, and you have to kind of then go back to behaviors that were not there under the THC. But many of those patients come back and say, wow, you know what, now I know just how much cannabis helps my child. If we don't see effects, we keep kind of titrating up looking for those effects. So it's not that you just stay at one dose for a really long time. If you're not seeing something, you would titrate up slow. But I tell people with CBD, give it a minimum of a week to 2 weeks just to see how you feel and see if you notice anything. CBD is not directly hitting that receptor the way THC is, right? You take a puff, you feel it, right? CBD is a little more subtle. I call it, like the late bloomer. You just have to give it a chance and see how it goes, okay? It was a THC. No, it was pure THC, no CBD. Those are not on the market anymore. In 2 patients, it caused seizures. Now, there are other people who probably could eat that whole candy bar, but I had 2 separate patients, one of which was like, he said to me, I'm an old hippie from the 60s. I thought I could take any amount of THC and be fine. But he ended up having a grand mal seizure and ended up in the hospital. The other was a 22-year-old boy who kind of just, wasn't really looking at the dosing and was just took too much. Remember now edibles only come as 100 milligrams total in a package in California, and each piece is individually has to be under 10 milligrams. And that's one of the reasons I think that that regulation came out, was because it has to be such that we don't create problems. Yes, sir.
So you're talking
Such a great question. So the question is, can you test your endocannabinoid system? Not yet. The study that I showed you from Stanford that showed plasma anandamide levels were lower in children with autism, in that study you'll see, if you read it, that there was a twofold goal with their the reason they were doing this study. One was to determine if children with autism had a dysfunction in their endocannabinoid system, but the other was to develop the blood test. So I suspect that now it exists, it will be available at some point. And remember too, look, I have a family that came to see me, they have their 5th child has autism, and the mom knew by about 6 months of age. She knew. She's an experienced mom. This child was not doing what the other kids did, and she had to wait till he was 3 to get diagnosed and to get funds to be able to have early intervention. Imagine if we have a biomarker, a blood test, for that mom at 6 months who says, I'm really concerned. And you get that and you show that, you can not only early intervention, but start augmenting the endocannabinoid system. There are a lot of genetic markers that look at your endocannabinoid system. Right now, there are even some companies that will say to you, oh, I can test your DNA and tell you how you're going to respond to cannabis. It's not there yet. I don't think it's unreasonable to look at that if you're curious, but a lot of those companies are giving you suggestions, oh, you might be dependent on THC. I don't think that's a good thing. If you're not kind of overdoing THC by the time you're about 20 or 25, you're unlikely as a medical patient when you're older to start abusing THC, right? I feel like some of those tests are giving information that probably they should not be giving. All right, let's move on. So drug interactions. So Rhonda mentioned there are some drug interactions. If you look at kids with epilepsy, really the big concern is a drug called clobazam or Onfi, and also a drug called Depakote or valproic acid. And these articles come from the CBD pharmaceutical called Epidiolex, where they were allowed to study what's going on. So you see here they took 39 adults and 42 children, and they gave them low to very high doses of CBD. I never go this high in my patients. And what they did was they drew blood levels before they gave the CBD, and then they drew blood levels of the drugs after they gave the CBD or after the patient was on CBD for a while. And what they saw was some increases in some of the drugs, but basically the take home is all the increases were within accepted therapeutic range except for Onfi. So Onfi is a benzodiazepine in the Valium family that's used for seizures. It has a breakdown product called N-desmethylclobazam, and basically these can kind of change when you are taking cannabis. So those are some things you have to be careful about. There was some increased liver function tests on patients that took valproate, which is also called Depakote, Depakine in that family. What was interesting is that once the valproate was lowered, the liver function tests normalized. So it was not irreversible damage to the liver. It was completely reversible by titrating the doses. And then here's just one more that came out that showed that 34 children with Dravet syndrome, which is a severe pediatric epilepsy, all they did was a test before CBD was added and after, and they found also a little bit of interaction with valproate, Depakote, and then also the clobazam. If your child is having intractable epilepsy and you're on a lot of drugs, you have to have a doctor involved. You should have a doctor involved in your cannabis care. All right, now this is Epidiolex. This is the pharmaceutical CBD. It's made from the plant, but they pull CBD out. It's basically a CBD isolate, okay? It's 99% pure CBD. Now, my big concern as a doctor is that it contains ethanol, and I had a mom that came in with a bottle of it. And why would you switch to it? Well, because it's covered by insurance. And cannabis, it's very hard for some of my families to escalate to higher doses because they can't afford the higher doses, and it's not sustainable. So why not switch if their doctor gave them, a neurologist gave them a prescription? So initially I was on board with this, and I thought it's fine. And I even caught some grief on Facebook. Somebody said, why are you promoting this crap? And I said, I'm not promoting it, but you don't understand the financial burden. You have a child with special needs to start off with is very expensive, and now you're adding, I've had patients pay $2,000 a month out of pocket for CBD oil, because that's the product that worked at the dose that worked. That is difficult. $24,000 a year out of pocket is very difficult. Now that's on the high extreme, and for some people it's not that much, but this allows some families to save some money and also get CBD. And as you can see here, it tests CBD total. You see the test result there, 98.55 milligrams per ml. They claim 100. That's pretty good. I've heard that they say no THC. There's a teeny tiny bit in there, 0.5% about. And as you can see, ND means not detected, so there's no other cannabinoids. So it really is narrowed down to CBD. But when you do the solvent test, you can see this is ethanol here. 2,871 micrograms per gram. Now the state allows 5,000. I'm a physician. I don't allow any. I don't let any of my pediatric patients. Why would you put ethanol in a pediatric medicine? I would not. These are kids that, they have livers from when they're this big. They're supposed to last them till they're, 90. So I struggle with this. And there are some patients doing okay on Epidiolex. The vast majority of my patients who called me and said they want to try it and switch have actually switched back to whole plant. And so it does look like it's helping some families get the same results. The two families staying on it got the same results, and so far no evidence of any lab changes. But with this, you're going to have to check liver function tests fairly frequently to make sure that you're not damaging the liver. All right, approach to epilepsy. So I start with high ratios, 30-to-1 to 18-to-1. I start with this dosing. Now, the reason I base it on pounds, and usually everything in pediatrics is based on kilos, because all the online calculators use pounds, so I try not to confuse anybody. There's a therapeutic range for most, although guess what? There's outliers. There's people that do better with less, and there's people that do better with more. If there's no success, we try different oils, or we might try adding in THC or THCA, CBDA. That all comes with kind of what I call the art of medicine, kind of the experience of the person who's helping you. There is no one standard approach. There can't be. Epilepsy is the name of many different conditions that fall underneath that. So this is just to kind of give you an idea that we do have a little bit of a protocol that we follow, but at the same time, we try not to cookie cutter it. It really is based on that particular patient's number of seizures. Are they responding? What other medications are they on? I have patients, I would like to give them every 8-hour dosing, but guess what? After school, they go to childcare. They can't get every 8-hour dosing. So they have to do a morning dose and a night dose. We might do something different for that particular patient than for a patient who is at home being cared for. So lots of different protocols for epilepsy. For sure, you want to pay attention to potential drugs interactions. Loss of effect after success. This is what we're talking about when we talk about a reboot, and I'll get to that. Can you just tell me how I'm doing on time? Okay, great. So autism, I'm going to go through pretty quickly here. The latest number, 1 out of 59 children, according to the CDC. And we know lots of features: communication, difficulties, repetitive behavior, social challenges, clear cut, and this should show a brain right here. Sorry, it doesn't show that. But a lot of neuroinflammation, neuroimmune abnormalities, and a lot of gut issues. So if you think about gut, brain, and immune system, what's dense in those three areas? Your cannabinoid receptors, okay? There's 2 FDA-approved drugs. Both are approved to treat irritability. They're not approved to actually treat the core symptoms or to improve them. It's just really to kind of calm the child down, I think. Both of these have significant side effects, as we all know. There's some research in the literature about using cannabis. There was a case report of using dronabinol, which is a synthetic THC, in a 6-year-old boy, and they had the parents assess, a doctor assess, and then also a separate clinical assessor, and they saw tremendous benefit at very low doses, 3.6 milligrams a day, and they saw less hyperactivity, less irritability, lethargy, the flapping, and better speech. So that was kind of interesting. And that goes back, almost 10 years now, right? And then there's been some, what we call preclinical in animals, showing that there's some genetic mutations may be associated that link the endocannabinoid system with autism. The real crux is here, though. So in 2013, they drew blood on children with autism and children without autism, and they found that children with autism had abnormalities in their type 2 cannabinoid receptors. As you can see, it says control here. They measured type 1 receptors, type 2, and this is the enzyme that breaks down your endocannabinoid, and this is the compound that kind of makes your endocannabinoid. And you can see in children that were healthy, these are all at the right expression, 100% expression, no more, no less. And in children with autism, it's all over the place. You can see that. And then subsequently, just last year, the plasma anandamide levels in the group from Stanford showed this is anandamide levels in children with autism, and this is children without autism. And this is just measuring a blood test, so it's obviously much lower. And it was to the point that the researchers were able to pick out which kids had autism based on the blood test, the probability of having autism without looking. And remember, now the diagnosis of autism is a clinical diagnosis. You have to see the patient, assess the patient to see what criteria they fulfill. In Israel, they're doing a lot of research on autism and using cannabis. Whole plant, high, what we call CBD rich. The ratio is 20-1 that they've chosen to use. And they took 60 children and they picked 60 kids with the most severe behaviors, okay? They were trying to help these families, and they decided to do kind of a preliminary study where you're not doing placebo, but you are giving cannabis. They started with a 20-1 CBD to THC ratio. They started at low dose and they titrated up. 52% of patients responded to this ratio. So, you know, like Rhonda was talking about, you have to figure out what works. Well, there's a 50% chance your kid's going to respond to this kind of ratio. That means the other 50% have to do something else. And so what they did was, in the group that did not respond to that ratio, they started adding in THC. So if you add in THC, that lowers the overall ratio, right? A little more THC relative to CBD. And what ended up happening was they went as low as 6-1, and lower ratio, they saw 22% much better, 12% slightly better, and they saw some worsening. But you can see the overall no change and worsening is only 15%. That's an 85% response rate, and that's pretty good in a group of patients for which there are not a lot of medications that are helpful. At the end of the study, 73% remained on treatment. That's always something good to look at. How many people want to stay on the medicine that they were given in the study? And when you look at who stopped treatment, some patients had irritability. Now, by the way, irritability and restlessness was one of the side effects. Oftentimes, again, like in clinical practice, it's different than in a study. If somebody's irritable on something, I change it up, right? So maybe that child needed a little more THC, or maybe they needed a different strain, or maybe they needed THCA. So remember, that doesn't equal failure. It just means this particular compound and this particular study design did not help that child. A couple of the patients had difficulty giving the oil and they dropped out. And then one girl had some transient psychotic event when THC was increased. I have not seen that in my practice. The range of dosing for CBD, a very wide range, 0.1 milligram per kilo per day up to 6. And THC was a little more narrow, and you can say that's probably a pretty good indication. That's what we see. With CBD, you can have low doses all the way up to really high doses. For THC, most patients are using low doses, although there are some high dose outliers. They showed, this is just a way to look at it in a graph. This is behavior improvement. The first two are very much improved or much improved, and then it kind of falls off after that. You can see that there's a large amount of patients' behavior, anxiety, and communication. And then they also looked at blood levels of endocannabinoids, and what they found was that the same thing they found at Stanford, which was those kids had low levels of anandamide as well in their group. They found no differences between the endocannabinoid levels in any medication subgroup. So if the kids were on medicine, it didn't change their endocannabinoid levels. If you took a benzo, if you took an antipsychotic, or you took a stimulant for like ADHD type behaviors, or SSRI, selective serotonin reuptake inhibitors, none of that changed their anandamide levels, and that kind of goes back to putting the Band-Aid on the toe when your arm hurts, right? It's not directly addressing the issue. There was no significant differences in the endocannabinoid levels in children with and without ADHD or epilepsy, and they found that children with higher severity or higher use of antipsychotics had lower levels of endocannabinoid. systems. So that's kind of our endocannabinoid levels. It's a pretty interesting finding. So I say kudos to Israel. They're doing a lot of the work that we should be doing here in the United States. Here's one more article that came from that similar group, 188 patients treated between 2015 and 2017. 30% reported significant, by the way, it was a 20-to-1 whole plant, okay? 82% remained in treatment at 6 months. About 83% reported significant or moderate improvement. And I still don't get the controversy. Yeah. All right, and their conclusion at the end, cannabis is safe, effective, and well tolerated. Whole plant, right. Yes, in Israel it's very well controlled. They have, I think, 9 dispensaries, and they have 91 total strains available, a handful of CBD strains, and they've fingerprinted all of them. There's a doctor in Israel that has a machine, equipment that fingerprints everything in the plant, which is kind of amazing. And he's able to really define, like if you see effect with one, he does a lot of cancer research. If you see an effect with one and not the other, you can almost narrow down what the differences are. That's what he's working on. Yeah, Dedi Meiri, yep. So this just shows you dosing in that article from Israel. This is dose of cannabidiol milligrams, so 15 milligrams here, 30 milligrams here, most dose 3 times a day. As you can see, some patients responded to low dose and some patients responded to really high doses. 285 milligrams 3 times a day is a pretty hefty dose. Some patients need that. It looks like the highest dosing range was somewhere between 45 and 75. I never get to say 100% in my practice. 100% of pediatric patients that come in whose parents have tried CBD for them have underdosed. 100% of them. So but part of that is not knowing what you're doing and not being sure and just being a little bit afraid, right? Here's quality of life assessment that they put out from Israel also. And if you pull out the paper, I'm sure you can get it on Whole Plant Access. You can see before treatment and after, before bad, after good, right? So you can see that. And then this is really interesting. I like this, although I would have liked for them to break down their no change or deterioration. What they showed was, here's restlessness. What percent of patients had improvement at 6 months? 89.8% improvement in restlessness, right? Big numbers. 89 for rage attacks, 83 for agitation, 58 for sleep problems, and so on. For deterioration, it would have been nice for them to break it down. It would have been helpful to see either no change or deterioration. That would be my request from them. But again, it still shows you that it's clearly there are some benefits and certainly worth exploring. For autism, this is kind of my approach. Combination of cannabinoids seem to be advantageous. I have to tell you, I have a boy that came into my practice. The mom's underdosing, but meanwhile it works. He came in on 4 milligrams of CBD. With the school approached the mom and said, "What are you doing?" He's a completely different child. So there are some kids at low dose that do well. So I always tell every family, you must start low dose, because if your child is in that low dose responder, you don't want to miss that. So start low, and then we escalate dosing. I talk about dosing here. Look at these wide ranges, 1 to 60, 1 to 50, 1 milligram to 20 milligrams. It's a lot. It varies person to person. It's very hard to come up with, oh, your child should take this. So anybody looking for help, just be aware. This is a bit of a marathon. It's not a sprint to the end. And just be slow and methodical. Start low dose. Don't be afraid to go higher dose. And try to get some medical supervision if you're struggling. In terms of adverse side effects, overstimulation is definitely something we see. CBD is an interesting compound similar to the other cannabinoids. All of these compounds have what we call biphasic or bidirectional effects. So bi means 2, right? Low dose does one thing, high dose often does the opposite. Think about THC. We all know at low doses THC can be anti-anxiety, but at high doses it can cause paranoia and anxiety. Exactly the opposite, right? CBD in low doses can be overstimulating for some patients. 10 milligrams can make some children bounce off the walls worse than they've ever bounced. And then we go high dose, and the higher doses are more calming and sedating. I've had patients say to me, I took 10 milligrams to try to go to sleep, and I was up all night. It was like a caffeine effect. Okay, take a higher dose. I say, what do you mean take a higher dose? I'm going to take a higher dose, it's just going to be more stimulating. That's not what happens with cannabinoids. You get an opposite effect often. And remember, it's individual. Some kids do great on low doses, some kids do better on high doses. You just have to find where that fine line is. In terms of increased appetite, for some patients that's a good thing, and for some patients it's not a good thing, and we do try to counteract that if that's an issue. And then insomnia, again, sometimes from that overstimulation. But what I tell everybody is we can try to adjust the dosing, the timing, the strain, to assess for the side effects. You don't ever have to have side effects with cannabis. You can always figure it out. Now, if I'm treating cancer, I usually give very high doses because we're trying to save your life. That I don't care if you're sleepy. Too bad. You're just going to rest, stay in bed. It's restorative. Yes, ma'am. So I do typically start with high, what we call CBD rich, so around a ratio 25 to 1, 20 to 1, 18 to 1. Oftentimes people buy a product before they come in. I try to work with them because they spent money on that. But if they have not purchased anything and there's no reason for me to not start with CBD, i.e. not a lot of drugs on board, then I often start with the high ratio CBD, and then I'll add in either THCA or THC as we move forward. Okay, and that's for autism. That's not necessary for epilepsy. Okay, the kids with combination, a little more nuances to the way we treat them. All right, I stole from Rhonda. Thank you, Rhonda, and Whole Plant Access for Autism. And this is about CBG. CBG is cannabigerol. CBG is not one of the main dominant compounds that the plant makes. Remember, the plants usually make either high THC or high CBD or a combination of those two, but you can harvest your plant in a certain way and also play with the genetics such that you can have your plant come out with high CBG. And there's a company here that has some CBG. If you're curious, go check out their bottles. But if you look at the survey, better mood, this is in 48 families, better mood in 30. Out of the 48, decreased anxiety in 23 out of the 48, increased in focus in 17 out of the 48, and so on. You can see the good is green and the negative side effects here in red. It's certainly worth a try. I got a email yesterday morning, a child on 3 milligrams of THC has a complete turnaround in all the autism behaviors. The school's already reporting just in the first 2 weeks. So sometimes I'll start with CBG, again, depending on what the family tells me they've tried in the past and so on. This particular child, the family was unable to afford high doses of CBD, and after we have that part of the conversation, we decided to try other compounds first before trying CBD. And again, when I say CBD, I mean CBD rich, okay? These are some of the strains that have been found helpful for kids with autism, and some of the terpenes, and then some of the varieties for THCA and THC. I know Whole Plant Access for Autism has very similar profiles that they have found to be helpful. Their website's really a great resource for this kind of information. The problem is you walk into a dispensary and somebody has a little bottle of, let's say, a 20 to 1 CBD to THC, and you ask what strain, everybody looks at you like, oh, who knows, right? So again, you can contact the company and ask them. Rhonda and Jenny, I know, call these companies and get a lot of information. They're very excited to hear that there's families with autism using their products. Yes, did you have a question?
I just want to go back to the cancer. What do you typically prescribe for your cancer patients?
Well, let's talk about it after. Okay, just find me, okay? Things to think about with pediatric patients: concentrated oil, always preferred. Remember, 50 milligrams in 1 ml. And let's say your child needs 50 milligrams. If it's 5 milligrams in 1 ml, you have to get 10 mLs into your child. Good luck. And 3 times a day. Good luck. So it's really important to understand concentrated is better, except for THC. We want low concentration so we can really titrate the dose. 1 milligram, 1.5 milligrams, 2 milligrams. Timing, often cannabis, as you know, cannot be given at school for the vast majority of patients, so timing sometimes plays a role. Consistency and reliable source. It's really important that you know if you found a particular product that works for your child, that the company is in tune with that the next month it's not a completely different strain. I had a family that got complete seizure freedom, this is a number of years ago before regulations, got complete seizure freedom on one particular product. And then the next bottle, we the child just fell off the cliff. So I said, the dad called me the good bottle and the bad bottle, we were calling them. And I said, just get the test results. They were completely two different strains, different terpene profiles. The first one was chock full of beta-caryophyllene and linalool, and the second one had neither of those. So it was clear cut for that child what was helping and what wasn't, so that helped direct us to find the appropriate product. Affordable. So people ask me all the time, is my child going to need this for the rest of their life? I don't know. This is brand new. We've only been giving kids cannabis for the last 6 or 7 years. So we don't really know. Can this change everything for them? I don't know the answer to that. I presume that if you have an endocannabinoid dysfunction, that may stick with you for life, but it's quite possible that you can cure it over time. I don't know. So I leave that one to be determined. Local access. I have families that drive 3 hours to get their medicine in a dispensary because that's the only dispensary that has it. So they have to hire somebody to watch their kids because the kids can't go in the dispensary. Access is a real big issue. So pester your politicians if they're trying to pass stupid things like no delivery in your area. And then lab tested, of course. Ill children, really, nobody should be taking medicine that's not lab tested. That just goes without saying. Now let's talk about reset or reboot. Many of you may have heard of this. So this kind of goes to tolerance and what we might call reverse tolerance. So what is tolerance? Tolerance is when you get a reduced response to a drug that used to work, but you've been taking it, and now your body has a different, it's not working, right? So opioids do that. If you take 3 Vicodin a day for 3 months, potentially your pain relief is going to start to go down if it was working for you because your opioid receptors get used to it. Same thing with cannabinoid receptors and THC. THC is the one compound in the plant that appears to cause tolerance. That's why, as by itself, unless you stay at very low doses, you may end up getting tolerance to it. Ways to avoid tolerance: change your strain, add some CBD in it, take breaks from your THC. When we look at CBD, it does not appear to cause tolerance. This may be still out. There was an article that came out of Israel after they did some of the research on epilepsy saying that as these kids stayed on these high doses, they started to lose effect. Well, when I see that, I actually take the CBD away because what we think is happening is that it's quite possible, I found one reference in the literature to reverse tolerance. So what's reverse tolerance is the opposite tolerance. Increased reaction to a drug following repeated use. Meaning, let's say you've been on 200 milligrams of CBD and after a while it stops working, you try to go up, it's really not working. What happened? Did I lose my effect? Go lower. CBD enhances your endocannabinoid system. If your endocannabinoid system is functioning better, you may not need as much. I liken this to you're in great shape, you don't need to hit the gym and overtrain. 3 times a week might work out really well. So what often we do is if, in the classic case of a child who needs a reboot or a reset, is they've been on a certain dose for quite some time, doing well, and then all of a sudden seizures start up again, and there's no reason. They're not sick, they're not bleeding another drug, there isn't something else that's new. And what we'll often do, especially if they've been at a high dose for a while, is we will discontinue the CBD between 1 and 3 days, and then restart at about 25% less dose, and often that will work. And sometimes we even have to go a little bit lower. This is, again, I'm giving you my understanding after speaking with a lot of doctors who study the endocannabinoid system. I've emailed and called all around the world and said, why would this happen? And this is basically what's happening is your endocannabinoid system is what we call upregulated. It's functioning well. It's doing well. You may not need as much medicine, okay? But I reserve the right to change that opinion when we get more science, okay? All right, now I wanted in the flyer that went out and the email that went out said we were going to touch on some other neurologic diseases, so I didn't want to leave out the people who came if they were interested in other research, and I thought this is real interesting. I have about 4 slides left, okay? Am I good? I'm over. Oh, is that okay? Can I go a few more minutes? Yeah, I got a thumbs up. Okay, so chronic inflammatory, so this is multiple sclerosis, and what is this? This is inflammatory autoimmune, okay? And what's happening is that you're starting to lose the myelin in your central nervous system, and it's a devastating disease, and it's the medications that treat it are pretty harsh.
Animal models show a combination of CBD and THC are better than THC or CBD alone for suppressing neuroinflammation, so you should be doing combination. Human trials show evidence of improvement in symptoms, so I've gone through all the research. There's clear cut that patients get some benefits in terms of pain, sleep, bladder issues, spasticity. There's a drug out called Sativex. It's approved in 30 countries, of course not the United States. It is a 1-to-1 ratio of CBD and THC. They are isolates. I think there's a little bit of terpene in there. But so far, Sativex has been shown to help a lot of patients. If they stay low dose, no tolerance is built with that 1-to-1 ratio. And so remember, a little bit of CBD in there can help prevent tolerance. But at the same time, there's no evidence that it stops the progression of disease. I have some MS patients I've been taking care of for many years who have actually been in remission for a long time, but part of their approach has not just been cannabis alone. It's been a very clean diet and a ton of exercise. So they have found that adding those, and some supplements, as anti-inflammatory supplements as well. I report in my kind of survey of my patients, high dose ratio CBD in combinations, and also for some patients adding in THCA will help if they still have pain and spasticity. When we talk about stroke, so there's a lot of information looking at stroke right now, and it looks like that there's a lot of conflicting data. It's hard to know exactly in animal studies. When we talk about this is the receptor, CBR, it's a cannabinoid receptor. Agonist means it binds to, antagonist means it blocks. So there's a lot of conflicting data, but overall, CBD has been shown to be protective for stroke and what we call neonatal hypoxia ischemic encephalopathy. So when a baby goes without oxygen or without blood flow to the brain, they end up having brain damage, but there's clear cut in animal models. Infarct volume means the amount of brain tissue involved and improved early functional outcome with CBD. And apparently there's going to be this new trial that potentially, I think, maybe Martin, you know, there's a new, with human babies, they're going to be doing some trials in babies that have this potential brain damage. They'll be giving them CBD. And then CBD and CBDA were both effective in helping through what we call the serotonin receptors, help improving basically what's going on in the brain, so protecting the brain. And all of these compounds, remember, are neuroprotective. One of the reasons I have my 89-year-old father on cannabis is to help protect his 89-year-old brain. So it's important that we understand that there are no human clinical trials and everything should be benefit risk. I feel the risk of CBD in an elderly person is very limited. So I have no problem trying to prevent stroke or at least neuroprotect. Parkinson's, remember this is a neurodegenerative disorder and it's marked by multiple motor problems. So tremors, muscle rigidity, problems with movement. The area that's affected in the brain is what's called the basal ganglia, where you have a lot of dense cannabinoid receptors, and that area is now suffering with low dopamine, and dopamine is part of the treatment. There have been multiple studies. You can see 339 people surveyed, I believe this was in Europe, where after 3 months of use they reported much improvement. 17 patients didn't see benefit. Remember, always look at the study design. Was it too low dose or was it isolate? But it was well tolerated. 5 patients found CBD helpful for psychosis associated with Parkinson's. 21 patients found high dose, look at this dosing, 300 milligrams a day, helpful for function and well-being, and some people have benefits for sleep. Here's a study from 2014 where they had 22 patients who just smoked some THC-rich cannabis and found everything was significantly improved, and then 5 out of 9 patients found improvement in sleep and pain. To me, it's why not. It's well tolerated. If you can find your dose, it's legal where you live, go ahead and try it. If you know you have this neurodegenerative disease that's kind of marching on and you can't stop, I see no reason not to try to do some neuroprotection and enhance quality of life at the same time. Dementia, I think this is my second to last slide. Dementia is, as you know, a decline in mental ability. The most common type is Alzheimer's. There's been clear-cut research that shows that CBD and THC inhibit the deposit of protein. So Alzheimer's is when your brain makes abnormal protein and deposits in your brain, and then it irritates the brain cells so they can't function normally. And cannabinoids have been shown to inhibit the formation of the plaque. I even saw this on 60 Minutes. They had a researcher on talking about it. You guys may have seen that. Clinical trials showed 2.5 milligrams help with motor activity, agitation, appetite, irritability with no side effects. I do have a handful of families that I take care of who bring in grandma or great-grandma to see me for dementia, and we've had very good results with low-dose THC or CBD. We have not had to escalate to high dosing for either in most patients with dementia. For many people, it's just about quality of life and trying to have that person have a really good benefit. I will share with you, I have a 64-year-old patient who came to me. The doctor called me and asked me to see the patient. She was in terrible decline, early onset Alzheimer's, and she has responded incredibly beautifully to a combination of THCA and low-dose THC. She would not open her eyes, she would not participate in feeding herself, dressing herself, using the bathroom, getting out of bed, any of it. She had to have round-the-clock care, and now she's participating in all of that. She had lost her voice, she would not talk to anybody. Now she's walking around the house singing. She's able to get up, get dressed, go to the grocery store every day with her aide, and interact with people and have a quality of life. Her husband calls it a remarkable turnaround. It makes me sad that she had symptoms for 4 years and had to be so badly off before they got started, but at least we've been able to give her a better quality of life. This slide shows you some suggestions from Dr. Musso and Dr. Jahan Markoum, who's a cannabis researcher. It doesn't include, it came before. These were out, I think. They published this because a lot of people weren't aware of these, but they kind of came up with some things to try. So you can take a picture of that and kind of do your research. There is no one-size-fits-all with cannabis. It's really important that you understand that it is trial and error. That's inherent in the process. And one last thing I want to say, I'll just show my pictures of my patients. One last thing I want to say is that many people are confused about hemp versus marijuana. Raise your hand if you're confused and you need an explanation. Okay, so our federal government says 0.3% THC by weight and under is hemp. Okay, but that's not really what defines hemp. Okay, just that number, you're using that number alone to define hemp, and that is not what defines hemp, right? You get it. So there is a lot of CBD on the market that has lower than 0.3%, that is whole plant, very robust. It is a drug variety plant, not a fiber variety. So fiber variety is hemp. Drug variety is what we would call, like our government wants to call marijuana, right? Make it illegal. Hemp is allowed, marijuana is not. So drug variety by definition is, quote, illegal federally. But if you grow your drug variety plant low in THC, guess what you can call it and sell it as? Hemp. So I call it drug variety, medicine variety, masquerading as hemp. Because it's that definition of, it's 0.29. Oh, now I can sell it to whoever I want on the internet. Does that make sense to everybody? If it's over 0.3, by definition, by our federal definition, it's a marijuana plant. It is a drug variety. It's federally illegal. If it's under 0.3, now you may find it in a dispensary under 0.3 because the person marketing that or the manufacturer says, no, I want this. This happens to be a medical marijuana plant that I grew as medical marijuana, but it tested out under 0.3. And now I could call it hemp, but I'm going to call it marijuana and sell it in the dispensary. But they don't have to. They could put a label on it that says hemp. When you see hemp on a bottle, that means nothing. It means absolutely nothing. You must see what's inside the bottle with the test result. Okay, if you get a test result and everything is ND, not detected, not detected, not detected, and there's a teensy-weensy little bit of CBD, guess what it is? It's either isolate or it's a hemp, or it's a hemp variety, maybe, that they're growing really low and everything else, and it really is truly the fiber variety. I joke around that back in the day they used to say, don't smoke rope, smoke dope, okay? Does that help everybody? You want medicine. It shouldn't be illegal, but unfortunately that's where we are, but you want medicine variety. Can, quote, hemp help some people? Yes, hemp oil. I put hemp seeds in my smoothies. We eat hemp hearts in my house. We have hemp milk. We have hemp, all great nutritional value, great source of fatty acids for your brain. But for medicine, I want whole plant, robust cannabinoids, terpenes, and all of that. The only way to know what's in that bottle is to get a test result. If somebody says it's proprietary, move on, okay? That's all I have. Thank you.